Good evening, class. Tonight we'll be going over chapters 11, 12, 13, and 14, high-risk care, pre-existing conditions, gestational conditions of high-risk care, labor and birth process, maximizing comfort for the laboring woman. First chapter will be chapter 11, high-risk prenatal care and pre-existing conditions. Metabolic disorders, which are pre-existing conditions to high-risk pregnancies, are diabetes, thyroid disorders, any cardiovascular disorders, respiratory, gastrointestinal, integumentary, and central nervous system disorders, autoimmune disorders, as well as substance abuse. Diabetes is the most common Diabetes is the most common endocrine disorder associated with pregnancy. Pregnancy is complicated by diabetes and is considered high risk. Diabetes can be successfully managed with a multidisciplinary approach, and keys to an optimal outcome is a strict maternal glucose control during pregnancy. Classifications as type 1 or type 2, and there's other specific types caused by infection or drug-induced. GDM, or gestational diabetes, is any degree of glucose intolerance with an onset or recognition that happens during pregnancy. This is showing you the difference in the need for insulin starting at 13 weeks, where you can tell up to 20 weeks it's much less, and from 20 weeks on it increases until after the mother delivers. Fetal and neonatal risk and complications due to diabetes can be prenatal mortality risk is increased risk of respiratory distress syndrome, prematurity, intrauterine fetal demise, or IUFD, and polyhydramnios. An assessment and nursing diagnosis. You will interview the patient, provide the physical exam, assess any acute or chronic complications caused by diabetes, also assess lab, also interpret. Well, you wouldn't interpret, but you would see the lab, you would interpret somewhat. Baseline renal function, a UA and culture, hemoglobin A1C, and patient needs much more frequent monitoring in their care if they were diagnosed with a metabolic disorder such as diabetes. So the lab tests that you would see would be the baseline renal function, the UA culture, and hemoglobin A1C. You would most likely be performing most of these tests. In labor and delivery, there's not necessarily, like in the actual labor and delivery, there's not necessarily a lab tech. So the nurses, when the patients come in, the nurses do all the labs and blood work and cultures and anything that they need and send it to the lab. How to deal with gestational diabetes during pregnancy. Make sure that they eat the right amount of carbs. They eat a healthy breakfast. Breakfast is very important. Take prescribed medications as directed. Opt for a sugar-free diet. They're able to drink cinnamon tea. Make sure they get enough rest and monitor their sugar blood glucose levels regularly. Antepartum care would be making sure they understand a proper diet and exercise, insulin therapy, self-monitoring their own glucose levels, urine testing, and also fetal surveillance. Intrapartum care would be monitoring the patient closely for any complications that may arise, and this may require, depending on the complications, it may require C-section or cesarean, especially if the baby is macrosomic, possibly with the polyhydramnios and any other complications. Afterbirth care, insulin requirements decrease substantially. We showed you that on the slide a couple pages earlier. Gestational diabetes is causes risk to the fetus. So care management would be screening for gestational diabetes. Early pregnancy screening starts at 16 weeks if previously GDM or overweight pre-pregnancy. Screening is usually done between 24 and 28 weeks. Interventions for intrapartum would be glucose monitoring hourly, a possible infusion of insulin infusion, and avoiding any dextrose solution. So a patient that has GDM diabetes, regular diabetes, they should not have D5, which is the dextrose solution. So D5, be careful of what they're running in the IV line. Sometimes that's missed and they're given IV solutions, and that just causes their sugars to be erratic. So after birth, most return to normal, high risk of future GDM in pregnancies if they've already been diagnosed with GDM prior. They have an increased risk of developing type 2 diabetes, and that would be reassessed between 6 and 12 weeks after birth. Hypothyroidism, if left untreated, risk for infertility and miscarriage. Watch for weight gain, lethargy, a decrease in exercise capacity, cold intolerance, thyroid hormonal supplements, and monitoring the thyroid studies would be done. So thyroid hormone supplements, I can tell you that the new fad of CMOS that's going around has caused patients to have severe hypothyroidism. We've had a couple patients in the office recently that we couldn't figure out why their thyroid is so messed up, and they have no history. There's no other reason, clinical reason as to why their thyroid is so messed up, and they were taking thyroid medication. Well, come to find out, the patient was taking CMOS. So there's a lot of iodine in CMOS, and I know it's floated as a cure for health and wellness now, but that's very dangerous. So be good to be aware of that. That's why when you're doing your interview with your patient, you want to make sure you know all of the supplements and things that they're taking, as well as the medications that they're taking, so that you can recognize where there may be a problem caused by something that they're intaking. Excuse me. So maternal phenylketonuria is recognized a cause of intellectual disability and a cause by deficiency in the enzyme of phenylalanine hydrolase. Toxic accumulation of that substance in the blood interferes with the brain development and function, and the key is to prevent it, is to identify women with the disorder in their reproductive years. It should be advised against, the woman that has that should be advised against breastfeeding. A major cardiovascular changes during pregnancy that affect women with cardiac disease are an increased intravascular volume, decreased systemic vascular resistance, cardiac output changes during pregnancy and birth, and intravascular volume changes that occur just after childbirth. An increased incidence of miscarriages can occur. Preterm labor and birth is more prevalent. Intrauterine growth restriction is very common, and the incidence of congenital heart lesions increased in children of mothers with a congenital heart disease. Congenital cardiac diseases can include an atrial septal defect, a ventricular septal defect, a patent ductus arteriosus, coarctation of the aorta, and tetralogy. I can't say tonight. Tetralogy of Fallot. I should go back and erase this, but I'm not. It's an increased incidence with trisomy 21. Heart transplantation. Increased number of heart recipients are successfully completing pregnancies. So before conception, women must be assessed for quality of their ventricular function and a potential for rejection of the transplant. Conception should be postponed at least a year after having a heart transplant. Assessment and nursing, diagnosis, interventions while pregnant. antepartum. Therapy focuses on minimizing stress on the heart, signs and symptoms of any cardiac decomposition, and bed rest, as well as nutritional counseling. Cardiac medications should be taken as needed, and hopefully no indications for heart surgery. Intrapartum would be routine assessments for cardiac decompensation, getting blood gases, ABGs, ECG monitoring, promote cardiac function, and minimize the patient's anxiety. Anemia is another medical disorder in pregnancy. Could be due to iron deficiency, a folic acid deficiency, or as well as sickle cell hemoglobin pathology. Pulmonary disorders, asthma, exacerbations and remissions, hyperactive airways. Its effect on pregnancies is unpredictable. So they're at an increased risk for after-birth hemorrhage. Other pulmonary disorders such as cystic fibrosis. Infants of mothers with cystic fibrosis will be carriers of the gene. So with severe disease, pregnancy is often complicated by chronic hypoxia and frequent pulmonary infections. Exocrine glands produce excessive viscous secretions. Problems with respiratory and they also have problems with respiratory and digestive systems. Skin disorders induced by pregnancy can be vascular spiders, pulmonary erythema, striae gravidarum, and melasma. Other disorders could be pruritus, gravidarum, PUPS, and intrahepatic cholestasis of pregnancy. Epilepsy. The failure to take medications is a common factor. Should receive preconceptual counseling. They're at risk for congenital anomalies if the mother is taken anticonvulsants. We talked about that before, so anticonvulsants can cause congenital anomalies. MS, or multiple sclerosis, will require bed rest and steroids used to treat acute exacerbations. Bell's palsy is the acute facial paralysis. Autoimmune disorders, myasthenia gravis, is an automotor muscle end plate disorder. So muscles weakness are in the eyes, face, neck, limbs, and respiratory muscles. Women with MG usually tolerate labor well and may require forceps or vacuum for delivery due to their muscle weakness. Screening, so it's first done on the first prenatal visit. Past and present use includes, we're talking about substance abuse, so screening is done during the first prenatal visit. They ask about past and present use. It includes prescription and herbal substances. Should approach these patients non-judgmentally. Toxicology testing can be done with urine, meconium of the baby, and hair. Usually when we do toxicology tests on the babies in the NICU or in nursery, there's a little bag that's made that pretty much fits on the baby for urine and meconium. And once they produce urine or meconium, it kind of holds it in there, and you're able to pour it into the container that you need to send it down to the lab. Substance abuse continued. So interventions, medical management, education, consequences of drug use, monitoring, and also there's treatment programs. Nursing interventions would be a low threshold for pain, requires additional approaches to management because these patients have had medications that blunt or cover up their opioid receptors. It's harder to get patients that are have a substance use problem or opiate substance use problem under control with pain when they actually have surgery or with childbirth. Decreased involvement with the infant requires advice and education, and considerations for breastfeeding related to the infant's exposure. So if the patient is still currently having issues with substance abuse, you obviously wouldn't want them to breastfeed. Follow-up care. So assess the safety of the home environment. This is usually done with care management. Social services may be involved. Most likely they're involved with everyone that comes in with a known substance abuse history. Case managers, consultants following delivery. Their availability of friends and families for support systems is important, and there will be home care visits. If the infant's well-being is questioned or questionable, a case will be referred to Child Protective Services agencies. So most of the time, care management or case management knows, or Child Protective Services knows, that there's a patient that's pregnant that is close to delivering. They will send a letter with their name and how many weeks they are and the possibility of them coming into the local hospitals for an alert to be called if that patient shows up at the hospital. This is done at every hospital. There'll be an update. We have like a little board, and it has the patient in case they're coming in because they're expected to come in to have a baby soon, and to call the Child Protective Services agency. Chapter 12 is high-risk prenatal gestational conditions. These disorders are that did not exist before pregnancy. These are disorders caused by pregnancy. So occurrence puts the woman and the fetus at risk. Hypertension in pregnancy, hyperemesis, hemorrhagic complications, trauma, and UTIs or urinary tract infections. Hypertension in pregnancy is significance and incidence. So preeclampsia complicates pregnancy between 5 to 10% of all pregnancy. Hypertensive disorders of pregnancy are the most common medical complication during pregnancy. It's a significant contributor to maternal and perinatal morbidity and mortality. Hypertensive disorders in pregnancy include gestational hypertension, preeclampsia or eclampsia, chronic hypertension, and preeclampsia superimposed on chronic hypertension. So gestational hypertension classifications is the onset of hypertension without proteinuria after the 20th week of pregnancy. So after the patient reaches 20 weeks of pregnancy, she has hypertension but does not have protein in her urine. Preeclampsia is pregnancy-specific syndrome, so hypertension that develops after 20 weeks. And previous normotensive women, so previous women with no problems with hypertension. It's a vasospastic system disorder characterized as mild to severe. Eclampsia is seizure activity or coma in women that are diagnosed with preeclampsia. They have no history of a pre-existing pathology, and eclamptic seizures can occur before, during, or even after birth. So it's very important to be aware of their blood pressure before, during, and after birth. Chronic hypertensive disorders are present before pregnancy. So initial diagnosis is done during pregnancy, and it lasts more than 12 weeks after birth. Etiology is signs and symptoms develop. We're going back to preeclampsia. Etiology, signs and symptoms develop only during pregnancy and disappear after birth. Associated high-risk factors include a family history, multi-fetal pregnancy, African American race, obesity, being younger than 19 and older than 40, and having any pre-existing medical or genetic conditions. Pathophysiology is the progress along a continuum from mild to severe. It's caused by disruptions in the placental perfusion and causes reduced kidney perfusion. Here's a better picture of preeclampsia pathophysiology. So you see the placental hypoperfusion, baby screaming, I want a belly button, and the placenta screaming, I can't breathe. Its curative treatment for this preeclampsia is delivery, so getting the baby out. Systemic constriction and endothelial dysfunction, so hypertension and end organ damage. You see the kidney leaking proteinuria, and you see the liver screaming help, so you're worried about hemolysis, elevated liver enzymes, low platelets. HELP syndrome. The diseased placenta releases inflammatory proteins into the maternal circulation. Here's a good picture of preeclampsia pathophysiology. So HELP syndrome is diagnosed through laboratory results. A variant of severe preeclampsia involves liver dysfunction characterized by hemolysis, elevated liver enzymes, you will see, low platelets. So it may be diagnosed as partial HELP or incomplete HELP. It has nonspecific symptoms that are reported, and it's worsened at night and improves during the day. HELP syndrome. So when they're diagnosed with HELP, they have an increased risk of pulmonary edema, acute renal failure, liver hemorrhage or failure, DIC, placental abruption, acute respiratory distress syndrome, sepsis, stroke, and fetal and maternal death. So it's very important to prevent that by keeping the blood pressure under control. Prevent that by looking for the signs in the blood work to start treatment if that is noticed. Interventions. Gestational hypertension and preeclampsia without severe features. Safety of the mother and the fetus is most important. So deliver the baby as close to 37 weeks as possible, and they're treated outpatient and home management. Maternal and fetal assessment lab testing is done, assess for signs and symptoms. The blood pressure is taken twice weekly in the office. The fetal movement counts are recorded, and non-stress tests are also done. Activity restrictions has no evidence to support any benefit. Here's a good picture of the edema you will see. So there is a normal foot on the left, and on the right, the poor swollen edematous foot. This is showing you 1, 2, 3, and 4, showing you pitting edema. Eclampsia, immediate care is needed. So maintain a patent airway if the patient's having seizures, and safety during the seizure. Make sure she doesn't hit her head. Make sure there's pillows around the sides of the rails of the bed. The rails are up. Stabilize the mother after the seizure. She will start a magnesium infusion if she isn't already on it. And you need to be aware of the baby's status. Prevention is key, so prenatal care for assessment and early interventions. Chronic hypertension is associated with increased incidence, so placental abruption, superimposed preeclampsia, heart failure, acute kidney injury, and fetal effects include intrauterine growth restriction, death, and premature birth due to chronic hypertension. Hyperemesis gravidarum. It's the excessive vomiting accompanied by dehydration, electrolyte imbalances, ketosis, and astonuria. Etiology, clinical manifestations and care management, assessment and nursing diagnosis, initial care, and follow-up care. So these patients most likely come into the hospital. They need fluids, definitely. They need the electrolytes replaced for the imbalance, and they need anti-nausea medications, usually given between Phenergan and Zofran. Hemorrhagic disorders in pregnancy are medical emergencies. So maternal blood loss decreases the oxygen carrying capacity. So increases the risk of hypovolemia, anemia, infection, preterm labor, and preterm birth, and it adversely affects the oxygen delivery to the baby. So if the mother doesn't have oxygen or she's losing all this blood, the baby's not getting what it needs. Fetal risks include with blood loss, anemia, hypoxia, hypoxemia, anoxia, and preterm birth. Cervical insufficiency is due to impaired cervical strength. The diagnosis is an OB history of preterm births or late miscarriages. Usually management is done by cerclage, where they put stitches or a stitch in the cervix until they get close enough to where the baby would be viable, preferably 37 weeks. Follow-up care, they're closely monitored. They have to report signs and symptoms of preterm labor. Sometimes they are put on bed rest. Molar pregnancy is an incidence and etiology. There's different types. Complete and partial and clinical manifestations can include blood loss and anemia. So diagnosis is done by transvaginal ultrasound and serum hCG. Management could be suction curettage or coping with loss. Follow-up care, weekly hCG monitoring, and frequent pelvic examinations. The entire uterus is filled with abnormal vesicles, and there's no sign of a fetus. So this is a picture of what a molar pregnancy looks like. Late pregnancy bleeding, so placenta previa. The placenta is implanted in the lower uterine segment near or over the internal cervical os. Classification is based on the degree of internal cervical os is covered by placenta. It can be complete, marginal, or low-lying. To the left, you see a normal placenta. It's up high in the uterus. The umbilical cord attached to that, and then the baby's head's closest to the cervix. The placenta previa, that is a complete placenta previa because the entire placenta is sitting over the cervix. So you can see that if the cervix opens, the bleeding from the placenta will decrease the oxygen to the baby as well as cause the mother to bleed, and you can see where that problem can start. Premature separation of the placenta or abrupto placentae is a incident in etiology. It could be due to smoking, it could be due to cocaine use, it could be due to trauma. Classification symptoms include grade mild, moderate, and severe. Management would be expectant and active management. Here's a picture of a partial separation and a concealed hemorrhage. So you're not aware that there's been a separation of the placenta. The baby might start to look bad on the monitoring though, and usually that blood comes flowing out after the baby's delivered, as well as the complete separation. The placenta is completely separated off the side of the uterus and is hemorrhaging. Partial separation of an apparent hemorrhage is where this placenta is partially separated, but the blood is able to leak out through the cervix. There's other causes of late pregnancy bleeding, including where the cord is inserted and placental variation, so vesa previa and velametis insertion of the cord, where the cord is not in the middle where it usually is. Here's vesa previa. Clotting disorders in pregnancy. Clotting problems, recognition in an antepartal period may decrease hemorrhage problems in the birth period. DIC is a pathological form of diffuse clotting, widespread external and internal bleeding. It's triggered by severe preeclampsia, HELP syndrome, and gram-negative sepsis. Management is to treat the underlying cause and assess for the signs of bleeding. Infections acquired during pregnancy could be STIs, UTIs, asymptomatic bacteria, cystitis, pyelonephritis, and patient education with regard to infection and management and prevention is important. Trauma during pregnancy, the significance is underreported. It could be due to motor vehicle accidents or falls. The use of seatbelt is very important. It depends on the effects of such trauma, depends on gestation, type and severity of the trauma, and the disruption of physiologic features. Management would include immediate stabilization, primary survey, so cardiopulmonary resuscitation, so uterine displacement necessary to facilitate proper blood flow, so you tilt them to one side, tilt them to their left side. So all the blood goes towards their heart. Secondary survey could be electronic fetal monitoring, fetal maternal hemorrhage, diagnosed on ultrasound, or radiation exposure. Perimortem C-section delivery. This needs to be done if it needs to be done due to the mother dying. It needs to be done in no more than 3 minutes after. Chapter 13, the labor and birth processes. So there is at least 5 factors that affect the process of birth and labor. The 5 P's, important. Passenger, the fetus and the placenta. Passageway is the birth canal. Powers are the contractions, the position of the mother, and the psychologic response. Passenger includes the size of the head of the fetus, the fetal presentation, how the baby is, the fetal lie, the fetal attitude, and the fetal position. This is showing you the baby is left, pointing, head is left occiput, transverse. So baby is coming from the left pelvis, or presenting from the left occiput, so his head, and transverse. So he's pretty well parallel with the mother. Left occiput posterior. So the head is presenting the left back of his head and posterior. Right occiput posterior, right occiput transverse, and right occiput anterior. The longitudinal or vertical, the lie is longitudinal or vertical. The presentation is vertex. The reference point is occiput, and the attitude is general flexion. So the baby's inflection. Not good ways to present. So frank breech, where the legs are straight up by the head. Single footing breech, one foot comes out first. This could cause hip dysplasia. Baby's not coming out most likely that way. Babies that come out that way are usually could be preterm, because once the head usually comes out first, and the cervix kind of pushes back, so you don't want the feet to come out first, because it kind of could cause decapitation once you get to the head. Complete breech, C-section. Shoulder presentation, C-section. Vertex presentation is the top one. I can't see. And brow presentation, that's most likely going to be a C-section as well. When we're talking about the patient being 0 to 10 for her cervix. They're talking about the size of the cervix, then they're talking about how thick the cervix is, 0 to 100, and then they're talking about position. So +1, -1, plus -3. You see where the ischial spines are is at 0. So when the baby's plus, the baby's pretty close to being delivered. +3, baby will be out. Negative, baby's pretty high. So it'll take a lot of pushing for a while to get down to where they need to be. Passageway. Our birth canal is composed of the bony pelvis and the soft tissues. The powers can be primary and secondary. Primary would be her contraction. Secondary could be due to oxytocin. And then you have the position of the laboring mother. It's always good while you're in delivering or getting ready to deliver to move. So turn her to the right, turn her to the left, sit her up in frog leg position, sit her up in throne position. It's always good to move from side to side. Laying in the same spot to waiting for the baby to come is going to take forever. Here you have a picture of the internal and the external os. So when you check a cervix, sometimes you can feel 2 different openings. So you have the internal os that's noted at the beginning of the cervix thinning. Then in B, you have the external os noted and the internal os has already opened. Then in C, you have the internal os is completely gone away. The external os is most likely probably 80% effaced. And then you have D, where the cervix is a 10 with 100% effaced, meaning there's nothing there. That's completely, the thinning of the cervix is finished. And the baby is most likely in +1 station. The process of labor. So labor is the process of the fetus, the moving fetus, the placenta, and the membranes out of the uterus and through the birth canal. Various changes take place in women's reproductive systems in days and weeks before labor begins. So labor can be discussed in terms of mechanisms involved in process and stages women moves through. Signs of preceding labor could be lightning or dropping, bloody show. When you see a bloody show, you'll see like mucus and blood on the pad that's sitting under the mother. And when you see a bloody show, you know that the baby is coming. The onset of labor. Onset of true labor cannot be ascribed to single cause, so many factors involved, including changes in the maternal uterus, cervix, and pituitary gland. Stages of labor start with the first stage, the onset of contractions, to full dilation, or 10 number of the cervix. The cervix will fully dilate to 10. The second stage is full dilation to birth, and the third stage is birth until delivery of the placenta. The fourth stage of labor is 2 hours post-delivery of the placenta. So after the fourth stage of labor, the mother is carried over to her normal room and out of the birthing room, out of the labor and delivery room, because she's done her post-delivery. She's stable. She's heading over to the maternal newborn side. Mechanisms of labor. There's 7 cardinal movements of labor that occur in the vertex position. So engagement. So the head engaging into the pelvis, the descent of the head, the body, the baby through the pelvis, flexion, internal rotation, extension, restitution, and external rotation, and expulsion, which ends in birth. Physiological adaptation to labor includes fetal adaptation, fetal heart rate, fetal circulation, and fetal duration. Maternal adaptation is as a woman progresses through stages of labor, various body system adaptations cause her to exhibit both objective and subjective symptoms. Maternal adaptation is cardiovascular changes, respiratory changes, the renal changes, skin changes, musculoskeletal changes, neurologic, gastrointestinal, and endocrine changes. Pain management, chapter 14. So neurologic origins. There's visceral pain from the cervix changes, the distension of the lower uterine segment, and uterine ischemia. Located over the lower portion of the abdomen is referred pain. It originates in the uterus. It radiates to the abdominal wall, lumbosacral area of the back, iliac crest, gluteal area, and down the thighs. Somatic pain is pain described as intense, sharp, burning, and localized. It's caused by the stretching and distension of the perineal tissue and pelvic floor to allow the passage of the fetus from distension and traction on the perineum and uterocervical supports during contractions and lacerations of soft tissue. Two neurologic origins is the first stage of labor is visceral pain. The second stage of labor is somatic pain, and the third stage is similar to the first stage. Perception of pain, the threshold remarkably similar in all, regardless of gender, social, ethnic, or cultural differences. Differences differentiate definitive roles in person's perception of and behavioral responses to pain. So pain tolerance refers to the level of pain a woman is willing to endure. The expression of pain. Pain results in physiologic efforts and sensory and emotional affective responses. So emotional expressions or suffering often causes increased anxiety. You'll see writhing, crying, groaning, gesturing, hand clenching and wringing, and excessive muscular excitability. Cultural expression of pain also varies. There's physiological factors, culture, anxiety, previous experience to pain, gait control theory of pain, comfort, support, and the environment. Non-pharmacological pain management measures are often simple, safe, few adverse reactions, and inexpensive. It provides a sense of control over childbirth, and methods require practice for best results. So patients that want to have a non-pharmacological birth or non-pharmacological pain management birth need to take classes. So birthing classes are very important. It makes a huge difference of a patient that comes in that has had a birthing class and is going to give birth compared to a patient that has read stuff and just thinks she's going to come in and have a baby with no pharmacological management. They oftentimes fail. Now there's women that have done well, but the women who are actually know what they're going to expect and are taught in the class how to cope with the pain do a lot better. So there's a variety of methods and seek alternatives, including pharmacological methods if measures used are not effective. Childbirth preparation methods, so relaxation and breathing techniques, focusing and relaxing techniques, breathing techniques, those are all taught in classes. Sure, with birth coaches. You have counter pressure and effleurage, touch and massage. So counter pressure is when the patient is going through birth and she's laboring. A person can take and put their hands on her lower ischial spines or lower back and push pressure into like the sacral joints as she's having the contractions, and that does help. Touch and massage, applying heat and cold, so sitting in a hot shower with the heat beating on your back, cold acupuncture, acupressure, and as well as transcutaneous electrical nerve stimulation or TENS unit. Here's a picture of counter pressure. So the laboring mom is laying over a birthing ball. The husband's in the front supporting her. The nurse is checking the baby's heart tones. And it looks like the doula, she's pushing counter pressure while she's contracting. There's a little baby born. Other non-pharmacological pain management could include water therapy. Usually it's a pretty hot sauna tub. Intradermal water block. Aromatherapy, so the essential oils are helpful. Music, hypnosis, and biofeedback. Here's a picture of a water birth. She's sitting in somewhat of like a throne position in the tub with her doula or support person and the OBGYN or nurse midwife. Pharmacological pain management during birth could be sedatives or analgesia and anesthesia. The anesthesia is done. You're not put to sleep to have a baby, but anesthesia is done during a C-section. Could be a spinal or complete put to sleep. Analgesia, anesthesia, so you have a nerve block. So localized perineal infiltration anesthesia, where they can just block the perineal area. They can block the pudendal nerve, a spinal, an epidural, combined spinal and epidural. Continuous contraindications to epidurals could be patients that have had several tattoos on their back. It's pretty hard to, that's a little difficult. And also patients that have scoliosis, other kind of back problems, neurological problems. And epidural does have effect on the newborn. So when the mother is getting the epidural, the heart rate on the baby will always drop a little because the mother's heart rate and blood pressure drops. So you want to make sure the mother's laying towards her left side when she lays back for the epidural, and keep an eye on the baby and make sure the baby's getting enough oxygen. And usually the baby gets a little bit better. It takes a couple minutes. Here's a pudendal block. So they're blocking the pudendal nerve. Other types of pharmacological pain management is nitrous oxide. They were starting to use that more when I left labor and delivery, and we did not have that at our clinic. But then you have general anesthesia, which is done in case of emergency. And a C-section, if the mother is extremely anxious, usually that's done. Here's spinal versus epidural. So spinal involves injecting the anesthetic drug into the cerebral spinal fluid, and the epidural involves injecting the anesthetic drug to the epidural space. The spinal anesthesia doesn't use a catheter, and the epidural does use a catheter, and the catheter stays in place until after birth. The spinal can be used for the lower limb and pelvic surgeries, and the epidural can be used for lower limb, pelvic surgeries, and childbirth. Here's a picture of the epidural block. It's much lower than the spinal block. And here is for vaginal delivery, the epidural goes to about the perineum, a little bit above the perineum. And for the cesarean birth, the spinal epidural, or the regular epidural that's just dosed high, is right below the breast. Here's a picture of an epidural. That's the catheter. So when you take the catheter out, at the end you can see these little black ticks, little black lines in the catheter. At the end of the catheter, there's one of those lines. So when you pull the catheter out and that line is there, you know that you got the entire tip of the catheter when you removed it. Non-pharmacological interventions and pharmacological interventions. So pharmacological interventions, you'll need informed consent. Consent should be signed. Timing of the administration. So you do a timeout, time when it's done, time when it started, time when the bolus dose is given. You'll prep for the procedure. It's done sterilely. Administer of the medications through IV, IM, or regional anesthesia, and safety and general care is taken. Okay, that was chapters 11, 12, 13, and 14 in your book. Hope you guys have a good night.